One, my name is Rocio Torres, and I am with the Overdose Data to Action States OD2A as at the Arizona Center for Rural Health. Before I introduce our speaker, I have some housekeeping information. Please mute yourself during the presentation unless you would like to participate in the group discussion. We will send a follow-up email with our slides, resources, and link to our website with a recording. It is my pleasure to welcome everyone to this webinar and introduce our speaker, Dr. Mary Tulinnye. Dr. Mary Tulinnye is a distinguished psychiatric nurse practitioner with a Doctor of Nursing Practice degree from the University of Wisconsin-Madison, earned in 2013. She has dedicated the past 9 years to serving at the Mojave Mental Health Clinic in Bullhead City, Arizona, as part of the National Health Service Corps. In her role, Dr. Tulinnye has provided evidence-based psychiatric care to individuals facing addiction challenges. Outside of her professional work, she enjoys exploring the beauty of the Western United States with her family. Welcome, Dr. Tulinnye.
All right, thank you for that introduction. Let me start sharing my screen. All right, good morning, good afternoon, everyone. And before we dive into the presentation, I'd like to invite you to take a few deep breaths. You're probably coming from your work environment, and just to try to relax and prepare yourself for the presentation and recognizing that self-care is professionalism. So give yourself a minute to take 4 deep breaths and transition into this learning environment. And as we're doing our deep breaths, we also want to recognize that pain and substance misuse impact many of our lives. And it's very likely that all of you listening to this presentation today know of someone who has lost their life to opiate use, opiate overdose. I myself lost a nephew to an accidental opiate overdose, and it's truly an epidemic and affects all of our lives. So the information we discuss may be upsetting, and we want you to do your best to lean into the discomfort and respect if you need to take a break or leave the presentation. And we know prevention, harm reduction, treatment, and recovery work, as evidenced by so many individuals in recovery or recovered from substance use, substance dependence. So I'm always proud to give the University of Arizona's land acknowledgement, and even more so with November being Native American History Month. So we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the Odaha and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through educational offerings, partnerships, and community service. So again, the Center for Rural Health, thank you for allowing me to be part of this presentation today. And the mission of the Center for Rural Health at the University of Arizona is to improve health and wellness of Arizona's rural and underserved population. And the mission is to be a diverse team of experts reimagining and transforming healthcare for pain and addiction. They try to advance science to provide students, educators, professionals, leaders, and communities with evidence-based insights, therapies, and resources. Together, they strive to empower those of us affected by pain and addiction to thrive. So I got that wonderful introduction. I am Dr. Mary Tulinnye. I am being paid to conduct this webinar for you today. It is my great privilege and opportunity to do so, and I have no other financial disclosures or conflicts of interest to report. So again, we're just pausing to recognize all the people who have lost their lives due to accidental poisoning, substance use, misuse, and addiction, and their families and community. In 2022, 108,000 people died from a drug overdose in the United States. These death rates nearly quadrupled between 2002 and 2022. And we are just beginning now to see a slight decline in those numbers. But we continue to work to develop and implement evidence-based solutions for current and future generations. And that's what we're going to be talking about today. So a good speaker always gives an outline, tells you what they're going to discuss, discusses it, and then reviews. And so this is what that outline does. We're going to be concentrating on the 12 CDC recommendations with implementation diagrams to help you put these recommendations into practice. And here are our learning objectives: to understand the relevance of the CDC Clinical Practice Guidelines for prescribing opioids for pain that were updated in 2022, and to demonstrate practical ways that the guidelines can be implemented into healthcare settings. All right, then, for these next couple of slides, I think, Jill, you're going to comment.
Yeah, let me turn my camera on. So, sorry. Not work. Oh, it is on. Okay. Good morning, everybody. So we've been doing a multi-state collaboration with Arizona and Idaho and let's see, Washington, Oregon, Utah, South Dakota. So we're continuing this collaboration to provide this training for opioid, safe use of opioids, because it is one of our new measures under MBQIP that will be starting in 2025. And so we're giving you this education today, and then later on we will be passing on the safe use of opioids, to how to report that in one of the documents that will be uploaded for you to use. So thank you for joining us, and I'll turn it back over to Rocio and Dr.
Tulinnye,
Even.
it's so
Thank you.
hard. However you say it works well for me. Thank you, Jill.
Thank you, Dr. Tulinnye. And it's so French. It's so pretty.
All right. So getting into the heart of the discussion, talking about the background and the relevance of the recommendations. So the International Association for the Study of Pain defines pain, and we've all heard this. We've all been presented with this definition before of pain, and we're all very familiar personally with what pain is: an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So we know that pain is a complex phenomenon influenced by multiple factors, including biological, psychological, and social factors. This complexity means that substantial heterogeneity exists in the effectiveness of various pain treatments, depending on the type of underlying pain or condition being treated. So I think it's important, from my background in psychiatry, to recognize when you're dealing with pain, it has, in human beings, it has those two essential experiences, which was the sensory experience and the emotional experience, which are two distinct phenomena. And keeping in mind that for individuals that already struggle to regulate their emotions, pain can be an even more challenging experience, and just keeping that in mind as you relate to your patients and plan interventions for them. So prevention, assessment of treatment and pain is a persistent challenge for clinicians. And we see in one of the bullet points that pain is the most common reason adults seek medical care in the United States. So many of the patients that are coming to us are confronting pain issues. At the same time as we're striving to adequately address pain and safely prescribe opiates and not contribute to the opiate epidemic, it's essential to recognize that pain might go unrecognized amongst medical professionals, and some people, including members of marginalized racial and ethnic groups, women, older persons, persons with cognitive impairment, persons with mental health or substance use disorders, may find that their pain goes untreated. So a lot of the data that's been gathered really underscores opportunities for addressing specific long-standing health disparities in the treatment of pain. So just to give some factual examples of populations that may have their pain inadequately addressed. Patients who identify as Black or African American, Hispanic, or Latino, and Asian patients receive fewer postpartum pain assessments relative to Caucasian patients. Black and Hispanic patients are less likely than white patients to receive analgesia for acute pain. Among Black and white patients receiving opioids for pain, Black patients are less likely to be referred to a pain specialist, and Black patients receive prescription opioids at lower dosages than white patients. Racial and ethnic differences remain even after adjusting for access-related factors, the needs and preferences of the patients, and the appropriateness of the interventions. These disparities appear to be further magnified for Black and Hispanic patients. We know that geographic disparities contribute to increased use of opioids for conditions for which non-opioid treatment options might be preferred but are less available, like less access to physical therapy, less access to behavioral health, especially in the rural areas that you're practicing in. For example, adults living in rural areas are more likely to be prescribed opioids for chronic non-malignant pain than adults living in non-rural areas where other treatment modalities might be more accessible. And then just a comment that pain is probably felt even sharper when systematic failures are internalized as personal ones. So we know that because of the clinical, psychological, and social consequences associated with pain, including limitations in activities, lost work productivity, reduced quality of life, and pervasive stigma, it's essential that clinicians have the training, education, and guidance to effectively manage pain in their patients. So on the other hand, we have to acknowledge that communities that are impacted by these constraints also have strengths and can be used in their favor. So as we're talking about the difficulty for certain marginalized groups to access resources for pain, we also want to identify the strengths of these patients. So rural communities, for example, are very resilient. I come from the Midwest, Wisconsin, rural community, and I know for sure that we are very resilient. And I just want to mention in this presentation for all of you working at the critical access hospitals, I salute you. It's very easy to talk about reducing health disparities in the United States, but another thing to like put your, what do they say? Oh, the expression's escaping me, but you guys definitely are doing the literal work of helping these communities. And we know that the critical access hospitals, the rural health clinics, and the federally qualified health centers are really working hard to make a more equitable healthcare environment. So a systematic review published in 2014 by the Agency for Healthcare Research and Quality, AHRQ, which is an agency I believe your organizations have to report to, found insufficient evidence to demonstrate long-term benefits of prescription opioid treatment for chronic pain. And long-term prescription opioid use was found to be associated with risk for overdose and opiate misuse, among other risks. So again, this slide is just talking about some of the aspects that I already covered, that pain is a complex phenomena, that prevention, assessment, and treatment of pain is a persistent challenge, and that in doing our best to do no harm, we have to recognize that even within this environment, pain might go under-recognized for some marginalized populations, and we want to make the system more equitable. So again, just talking about prescription opioids remaining the most commonly misused prescription drugs in the United States, and that the majority of time people are misusing these drugs to address their pain issues. And the minority, 11.3 or less to feel good or get high, and 2.3% because they're addicted to the medication and they have to get it. All right, so just to open discussion briefly, so what are your state issues regarding opioid use, specifically in rural areas? So in the practice setting that you're in, what are some of the issues that you have? I could begin this discussion by saying that in Arizona, where I work, I am on a tri-state corner of the state. And so we border directly with Nevada, and California is literally like right across the street. Nevada's across the river, California is down the street. And so when we check our PMP, the Arizona Prescription Drug Monitoring Program, which I'll address again later in this talk, California's laws do not mandate that they report to the PMP. So I can't get that information on what scheduled medications my patient might be taking. So that's a significant barrier here in Bullhead City, Arizona, where I practice. And then if any of you want to unmute yourself and talk about what are some of your issues in your particular state regarding opioid prescribing, opioid use.
Or please put in the chat, either way.
All right, I'm going to go ahead and just keep moving here because we do have a lot of information to present, and hopefully at the end of the presentation, we have room for more comments and questions.
I think there was a comment. Did you want to take that now or later?
Yes, let's take it. Go ahead.
I think it was, yeah, it was Joshua.
Yeah, sorry about that. My name is Josh. I'm the director of pharmacy at White Mountain Regional. I'm on the other side of the state as you. I think something that we struggle with over here is just, I think access to resources on how to cope. We don't really have much mental health services up here, and a lot of them is telehealth. And while, you know, we're grateful to have that, I think that's a problem that we've seen in our community is coping with mental health challenges and even addiction recovery challenges. We don't have a lot of those resources, and so we're always looking for ways that we can help our patients in areas like that.
Mm-hmm. Yeah, and where exactly are you again, sir? Josh?
It's in Springerville, Arizona.
Okay.
It's about an hour east of Show Low, if you know where Show Low is.
Okay. All right. Yeah, definitely an issue. And you are right. The telepsychiatric services, they are better than the absence of all services, but definitely can fall short in some area and very difficult to assess for substance use or mental health issues and not have adequate referral system in place. Definitely a significant barrier. And one other barrier that I noticed, you know, when epidemics happen, you know, the opioid epidemic, the COVID, you know, issue that we went through, you can tell in these rural places that even though state and local mandates or laws are coming through to help, they're very slow, right, to trickle down to our remote areas. And the people that need help, they really can't wait for the interventions to trickle down. So definitely a legitimate concern that you're bringing up there, Josh. All right, so we're gonna move ahead to addressing healthcare disparities and promoting health equity, really the foundation, laying the foundation for that. So there's 5 priority areas discussed here. And in response to the alarming statistics of the opiate overdose deaths, national and statewide, some entities and organizations such as CMS have advocated and developed frameworks to further advance health equity, expand coverage, and improve health outcomes. CMS recognizes that addressing health and healthcare disparities and achieving health equity should underpin efforts to focus attention and drive action on our nation's top health priorities. CMS defines health equity as the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or other health factors that affect access to care and health outcomes. So we definitely have made a lot of efforts in that area here in the United States, but we have a long way to go. And as we discussed, healthcare disparities contribute to increased use of opioids, inadequate pain management, and access to prevention, assessment, and treatment. It's imperative that we pay close attention to guidelines like the ones that we're going to talk about in just a second. And then talking about CMS 5 priorities that range from data collection, which your organizations are directly involved of, reporting data, and use, to accessibility to healthcare services and coverage. So we're going to really try to see as we go along how we can connect the CDC guidelines with these health equity priorities. All right, so just beginning to talk a little bit about the history of the 2022 Clinical Practice Guidelines for prescribing opioids for pain. And why did they need to update the guidelines from the initial ones that came out in 2016? So in response to the alarming statistics, alarming national and statewide statistics, some entities and organizations such as CMS have advocated and developed frameworks to further advance health equity. And CMS recognizes that addressing health and healthcare disparities and achieving health equity should underpin efforts to focus attention and drive action on our nation's top health priorities. Healthcare disparities contribute to increased use of opioids, inadequate pain management, and access to prevention, assessment, and treatment. Is imperative that we pay close attention to the guidelines like this one that we'll talk about momentarily to better treat communities. And as Josh was saying, even though that access is imperative, sometimes our referral options are very limited. So we do our best. So the CMS 5 priorities that range from data collection and use to accessibility to healthcare services and coverage. So talking about the CDC Clinical Practice Guidelines, they're intended to be flexible and to enable person-centered decision-making, taking into account a patient's expected health outcomes and well-being. So I think that with the initial guidelines, people took them as strict mandates to get people off of opiates. And at that time, you saw perhaps an overcorrection of people like getting immediate discontinuation of their medications and strict guidelines being imposed by facilities that really tightly controlled the individual's decision-making practices. And that was not what was intended initially. So they really want to emphasize that the recommendations aim to improve, number one, communication between clinicians and patients about the benefits and risks of prescription opioids and other pain treatment strategies. Number two, they want to improve the safety and effectiveness of pain treatment to improve pain, but not only improve pain, really to assess how function is improved by addressing the pain, and really improve quality of life for persons with pain. And we also want to reduce the risks associated with opioid pain treatment. And we know what those risks can be: opioid use disorder, overdose, and death. So another reason that the clinical mandates, the clinical guidelines were not mandates, they're not mandates, they're guidelines, were updated in 2022 is they wanted to broaden the scope of the audience and just make sure that we recognize that they're applicable for outpatient settings that include clinicians' offices, clinics, and urgent care centers, and who they're intended for, primarily outpatient clinics or people that are being prepped to go out after surgery or being discharged from the ER. And they also include like dental care providers, urgent care clinicians, emergency clinicians, again, providing pain management for patients that are going to be discharged, occupational medicine physicians, just kind of broadening the spectrum of who is using these clinical guidelines to practice. So again, the clinical guideline is not for the management of pain related to particular diseases, in particular like sickle cell disease management, or cancer-related pain, or hospice end-of-life care. There are specific recommendations for treating those populations, and I believe that information for that's included on the CDC website, and you guys are going to get so many links with other sources of information for the safe prescribing of opiates at the end of this presentation. And they're not focused on opioids prescribed for opiate use disorder. So these recommendations in no way influence MAT, medication-assisted treatment for opioid use disorder. I might throw a few things in there about that as time permits, but they're not recommendations for the treatment of opioid use disorder. And they're not applicable to providing care to patients who are hospitalized in an emergency department or other observational setting from where they're going to inpatient care. Again, they're primarily for the outpatient clinic. So this slide right here just kind of shows how the recommendations have changed from 2016 to 2022. They were broadened to expand the scope of who could use the recommendations, from primary care physicians to like dentists, emergency rooms, surgeons preparing for post-op. The goals of the key areas were expanded, and the methods, we're going to talk a little bit about the methods, how we come to the grade framework. Like each recommendation is graded in terms of the robustness of the evidence that supports that recommendation. And there are 12 recommendations, category A and B. So the categories A and B kind of go like category A, this is applicable to everyone that you would be treating with the opiate, every adult patient. Category B goes more to specific populations, like for an example, the pregnant patient needing pain management. And then the 4 evidence types, again, goes back to that grading framework of how they're grading the robustness of the evidence. So the recommendations are grouped into 4 areas. So the 4 areas are determining whether or not to initiate opioids for pain. And I'd like to think that I have definitely already introduced the topic that opioids are not to be the first thing that we go to for pain, that many non-pharmacological and non-opiate-based medications should first be tried for pain. So then suggesting and advice on selecting opioids and determining dosages, and then deciding on duration of initial opioid prescription and conducting follow-up, making sure that you're not giving an unlimited supply of medication so that the patient's pain resolves. That patient has this unused medication that then can be stored in unsafe ways where it becomes a danger to the family, or shared with somebody who might have pain where it can be their introduction to opiate dependence or accidental opioid death. And assessing risk and addressing potential harms of opiate use. All right, so the 5 principles for implementing a cross recommendation. The 5 guiding principles are that acute, subacute, and chronic pain need to be appropriately addressed and treated independent of whether opioids are part of the treatment regimen. Recommendations are voluntary, are intended to support, not supplant, individualized person-centered care. Flexibility to meet the care needs and the clinical circumstances of a specific population is paramount. So again, going back to recognizing that these are recommendations and that they're meant to be flexible and not to supplant your clinical judgment in the individual patient's case. And they're meant to be multimodal and multidisciplinary approach to pain management, attending to the physical health, behavioral health, long-term services and supports, and expected health outcomes and well-being of each person being critical. Number 4, special attention should be given to avoid misapplying this clinical guideline beyond its intended use or implementing policies derived from this recommendation that might lead to unintended and potentially harmful consequences for patients. And I, from my own experience in Mojave County, saw that when those initial recommendations came out, people took them to the literal sense, and people were abruptly discontinued from their opiate pain medication, leading them to get into illicitly obtaining opiates, fentanyl, and all the complications that can go from that. So these are recommended guidelines, and always keeping in mind that first, we do no harm to our patients. So number 5, clinicians, practices, health systems, and payers should vigilantly attend to health inequities, provide culturally and linguistically appropriate communication, including communication that is accessible to persons with disabilities, and ensure access to an appropriate, affordable, diversified, coordinated, and effective non-pharmacological and pharmacologic pain management regimens for all people. Okay, so it sounds like a lot, and it is a lot, right? No doubt, right? How can we put this into practice? We don't do it all at once. We always keep in mind that these are recommendations and that they don't negate our clinical judgment. We start small and we set achievable and reasonable goals. And as we're implementing these, we're kind to ourselves and others in our organization, remembering that change takes time and consistency. All right, so now we are going to start the actual recommendations, the heart of the matter, recommendations 1 and 2. So the first recommendation number 1, non-opioid therapies are at least as effective as opioids for many common types of acute pain. As a clinician, you should be maximizing the use of non-pharmacological and non-opioid pharmacologic therapies as appropriate for the specific condition and patient, and only consider opioid therapy for acute pain if benefits are anticipated to outweigh risks to the patient. Before prescribing opioid therapy for acute pain, clinicians should discuss with patients the realistic benefits and known risks of opioid therapy. So non-opioid therapies are at least as effective as opiates for many common acute pain conditions, including lower back pain, neck pain, pain related to other musculoskeletal injuries, pain related to minor surgeries, typically associated with minimal tissue injury and mild postoperative pain. That would be like kidney stones, headache, those types of things. Clinicians should really try very diligently to maximize the use of non-opioid pharmacological treatments, such as topical or oral non-steroidal anti-inflammatory drugs, and non-pharmacological interventions like ice, heat, elevation, rest, immobilization, or exercise therapies as appropriate for the specific condition. Opioid therapy has an important role for acute pain related to severe traumatic injuries. Invasive surgeries, typically associated with moderate to severe postoperative pain and other severe acute pain when NSAIDs and other therapies are contraindicated or likely to be ineffective. When diagnosis and severity of acute pain warrant the use of opioids, clinicians should practice immediate release opioids, really reserving extended release, long-acting, and the opioids initially should be prescribed at the lowest effective dose and for no longer than the expected duration of pain severe enough to require opioids. Again, just really emphasizing that you don't want your patient left with these extra pain medications just sitting around their house. Clinicians should prescribe and advise opioid use only as needed, not scheduled. And if patients already receiving opioids long-term require additional medication for acute pain, non-opioid medication should be used when possible And if additional opioids are required, they should be continued only for the duration of pain severe enough to require additional opioids as quickly as possible, returning to the patient's baseline opioid dosage, including a taper to a baseline dosage, if additional opioids were used around the clock for more than a few days, so that they're not having withdrawal from the additional opioids. Clinicians should ensure that patients are aware of the expected benefits of, common risks of, serious risks of, and alternatives to opioids before starting out or continuing opioid therapy, and should involve patients meaningfully in discussions about whether to start opioid therapy. And I think on occasion, as clinicians, things can seem so obvious to us that we think it's obvious to our patient. Like, surely we think for that patient, they must be aware of the opiate epidemic, that people are dying from opiate overdoses, all the risks that are associated with that. But we can't make that assumption that patients are aware. And so we have to lay it out detailed to them of the risks of long-term opiate use. So recommendation number 2, non-opioid therapies are preferred for subacute and chronic pain. Clinicians should maximize use of non-pharmacological and non-opioid pharmacological therapies as appropriate for the specific condition and patient, and only consider initiating opioid therapy if expected benefits for pain and function are anticipated to outweigh risks to the patients. Before starting opioid therapy for subacute or chronic pain, clinicians should discuss with patients the realistic benefits and known risks of opioid therapy, should work with patients to establish treatment goals for pain and function, and should consider how opiate therapy will be discontinued if benefits do not outweigh the risks. So as soon as you're implementing that opiate therapy, you're talking about the exit strategy. And again, really concentrating on not just the goal to be the absence of all pain, because that may not be accomplished, but how can we improve your function? How can we improve your patient's function? To guide patients' specific selection of therapy, because we're going to try to make that decision together, right? A team effort. We're going to review with patients the juxtaposition of the benefits versus the risks and come up with that goal together. We should try to evaluate patients and establish or confirm the diagnosis. Clinicians should recommend appropriate, non-invasive, non-pharmacological approaches to help maintain chronic pain, such as exercise therapy, weight loss, yoga, all of these other non-pharmacological treatment modalities, Tai Chi, Qigong, acupuncture. Unfortunately, a lot of these treatment modalities are not going to be available in our rural underserved areas. But low-cost options to integrate exercise, you know, we have to make do like with what we can. You might want your patient to go get their exercise in the Walmart, you know, heat, the oppressive heat of Mojave County for 4 months out of the year make it impossible for many of my patients to get that physical activity. Also in the rural areas, it may be dangerous to get your patient up and exercising, even though we know complications of immobility definitely contribute to pain. So in these rural underserved areas, we really have to be creative as we're encouraging these interventions and not encouraging interventions that are unrealistic or impossible for our patients, because they definitely don't help and probably make the patient feel less empowered if we're encouraging interventions that they can't possibly go through with. So we can work to try to make health insurers and health systems responsible for improving pain management and reducing medication use and associated risks by increasing reimbursement for and access to non-invasive, non-pharmacological therapies with evidence for effectiveness. Clinicians should review FDA-approved labeling, including box warnings, and weigh benefits and risks before initiating treatment with any pharmacological therapy. NSAIDs should be used at the lowest effective dose and shortest duration needed, and should be used with caution, particularly in adults and older patients with cardiovascular comorbidities, chronic renal failure, or previous gastrointestinal bleeding. When patients with chronic low back pain have had an insufficient response to non-pharmacological approaches such as exercise, clinicians can consider NSAIDs or duloxetine, which is Cymbalta, for patients with contraindications. Tricyclic, tetracyclic, and SNRI antidepressants like Cymbalta is an SNRI antidepressant, selective anticonvulsants like pregabalin, gabapentin, oxcarbazepine, and topical ointments like capsaicin and lidocaine patches can be considered for neuropathic pain. In older adults, discussions to use tricyclic antidepressants should be made judiciously on a case-by-case basis because of risk for confusion, falls, cardiac risk. Duloxetine and pregabalin, so Cymbalta and Lyrica, are FDA approved for the treatment of diabetic peripheral neuropathy, and in my practice give significant benefits, significant results. They're also approved, the Lyrica and the gabapentin, they're FDA approved for the treatment of post-herpetic neuralgia. In patients with fibromyalgia, tricyclic and SNRI antidepressants, so tricyclics, that would be like amitriptyline or triptylene, and SNRI antidepressants like duloxetine, which is Cymbalta, NSAIDs, and specific anticonvulsants, again, the Lyrica, the gabapentin, are used to improve pain, function, and quality of life. Patients with co-occurring pain and depression might be especially likely to benefit from antidepressant medications. And just again, going back to opioids not being considered first-line routine therapy for subacute or chronic pain. Opioid therapy should not be initiated without consideration by the clinician and patient of an exit strategy to be used if opiate therapy is unsuccessful. So just bringing that up again, that as you're introducing the opiate therapy, you're also introducing the exit strategy. Before opiate therapy is initiated for subacute or chronic pain, clinicians should determine jointly with patients how functional benefit will be evaluated and establish specific measurable treatment goals. All right, so now we're moving on to the next three recommendation 3, 4, and 5 of 12. So number 3, when starting opioid therapy for acute, subacute, or chronic pain, clinicians should prescribe immediate release opioids instead of the extended release or long-acting opioids. Clinicians should not treat acute pain with ER or LA opioids or initiate opioid treatment for subacute or chronic pain with ER or LA opioids. And I think that we can say it's pretty concrete. You're not going with the extended release or the long-acting right off the bat. And these extended release and long-acting opioids should not be used for intermittent or as-needed use. And that's kind of an obvious, hopefully, to all of us listening today. ER and LA opioids should be reserved for severe continuous pain. The FDA has noted that some extended release long-acting opioids should be considered only for patients who have received certain dosages of opioids of immediate release opioids daily for at least 1 week. When changing to an extended release or long-acting opioid for a patient previously receiving a different immediate release opioid, clinicians should consult product labeling and reduce total daily dosage to account for incomplete opioid cross-tolerance. Clinicians need to use additional caution with extended release and long-acting opioids and consider a longer dosing interval when prescribing to patients with renal or hepatic dysfunction, because you don't want that level to build up in the person who is unable to clear the accumulation of drug, which can lead to toxic levels and unintended overdose. And methadone being used for pain should not be the first choice for the extended release long-acting opioid. Only clinicians who are familiar with the methadone's unique risk profile and who are prepared to educate and closely monitor their patients should be using methadone. And then just a quick add-in for methadone, even though we're not talking about medication-assisted treatment, if we go back to talking about the prescription drug monitoring program that you have hopefully embedded within your electronic medical record, and you are looking to see what scheduled medications your patient has received, if you have a patient who is in opioid dependence treatment in a methadone program, methadone will not be showing up on that PMP. So if your patient is receiving methadone for pain, yes, you will see it on the PMP. If your patient is enrolled in a methadone drug treatment program, that methadone will not appear on the PMP and does present a challenge to us as prescribers of opiates. To include the discussion of why it's not in the PMP would be too much for this discussion now, but I could talk about that after the program. So recommendation number 4, when opioids are initiated for opioid naive patients with acute, subacute, or chronic pain, clinicians should prescribe the lowest effective dosage. If opioids are continued for subacute or chronic pain, clinicians should use caution when prescribing opioids at any dosage. Should carefully evaluate individual benefits and risks when considering increased dosages, and should avoid increasing dosages above levels likely to yield diminishing returns in benefits relative to risks in patients. So recommendation number 5. For patients already receiving opioid therapy, clinicians should carefully weigh benefits and risks and exercise care when changing opiate dosages. So this can be a particularly precarious time. If benefits outweigh risks of continued opioid therapy, clinicians need to work closely with patients to optimize non-opioid therapies while continuing opioid therapy. If benefits do not outweigh risks of continued opioid therapy, clinicians should optimize other therapies, like we talked about, the physical therapy, non-steroidal anti-inflammatory, topical therapies, and really work closely with the patient to gradually taper to lower dosages. Or, if warranted, based on the individual circumstances of the patient, appropriate taper and discontinue opioids. Unless there are indications of a life-threatening issue, such as warning signs of impending overdose, opioid therapy should not be discontinued abruptly, and clinicians should not rapidly reduce opiate dosage. So this was a problem when the original guidelines came out. As I kind of mentioned, people were rapidly reducing and cutting people off of their opiates. Taper is recommended. And there are different guidelines that you can look up for appropriate taper. Some guidelines might say decrease by 10% every month. And I know a rule of thumb that I was given many years ago, and this was more for benzodiazepine taper. And we're going to talk about the issues that come along with the concomitant prescribing of opiates and benzodiazepines. And I believe Jill could confirm this later in the presentation, but this is a required reporting element, that you're reporting your patients who are prescribed more than one opiate and who are prescribed opiate and benzodiazepine. But just getting back to the rule of thumb with tapering, for instance, if you had a patient that was on a benzodiazepine for 10 years, then you would say, okay, it's going to take me 10 months to taper this patient successfully. And this was a recommendation for benzodiazepines, but can also carry over to the opiate taper. And you want to just be very careful, because your patient, it's well known that people are very much at risk for opioid overdose and death when they've been on a certain level, a certain quantity of consumption of the opiates, and then they go without them for a while. And then they reintroduce the opiate at the previous level, but their body is no longer able to metabolize that in an immediate fashion, and then they die from opiate overdose and death. So again, just going back to trying to do no harm to your patient as much as possible, and cutting them off dramatically is usually not going to help them overcome the risks associated with opioid dependence, opiate overdose, getting your opiates illicitly, recreationally, and death. So implementation considerations, just before we move on to recommendations 6 and 7, clinicians should carefully weigh both the benefits and risks of continued opioid medication and the benefits and risks of tapering opioids. If benefits outweigh risks of continued opioid therapy, clinicians should work closely with patients to optimize non-opioid therapies while continuing opioid therapy. When benefits, including avoiding risks of tapering, do not outweigh risks of continued opioid therapy, Clinicians should optimize other therapies and work closely with patients to gradually, key word here, gradually, taper to reduce opioid dosage, or if warranted, based on the individual clinical circumstances of the patient, appropriately taper and discontinue opioid therapy. In situations where benefits and risks of continued opioids are considered to be close or unclear, again, this goes into that shared decision-making with patients is particularly important. Really, the juxtaposition of patient goals and clinician goals are continued to make a team effort to come up with the goals. At times, clinicians and patients might not be able to agree on whether or not tapering is necessary. And I would say not at times, probably many times, patients and clinicians are going to be, their goals are going to be oppositional. And when patients and clinicians are unable to arrive at a consensus on the assessment of benefits and risks, clinicians should acknowledge this discordance, express empathy, and implement treatment changes in a patient-centered manner while avoiding patient abandonment. So you don't abandon the patient. You let them know that tapering may be associated with some discomfort, but you're going to be with them, and this is going to be a journey together. Patient agreement and interest in tapering is likely to be a key component for successful tapers, and I would add that as a clinician, your motivational interviewing techniques and your ability to get buy-in from the patient really, really play a significant role in their success of effectively tapering off of the opioids. And clinicians really need to collaborate with the patient on the tapering plan, including patients in discussions such as how quickly tapering will occur and when pauses in the taper might be warranted. Really just trying to give the patient a sense of so they feel not in control, and they really are not. It's up to you to prescribe these medications. They're not in full control of the access. So just giving them, empowering them, making them feel as empowered and involved in the treatment decision as possible. And as a nurse, I can definitely tell you that a good way to approach your patient is not by telling them what you're not going to do. The patient saying, I need this, you're saying, no, I can't do that, is never a good way to lead. It's always a good way to lead to say, this is what I can do for you. I can do A, B, C, and D, and let's talk about what I can do for you. And that's a good way to lead and make the patient feel empowered. All right, so moving right along to recommendation number 6. When opioids are needed for acute pain, clinicians should prescribe no greater quantity than needed for the expected duration of pain, severe enough to require opiates. So again, you're not putting multiple refills on your prescription, and you really are doing your part to make sure there are not excess prescribed opiates out there that can contribute to the epidemic of addiction, can be shared, resulting in overdose deaths. Recommendation number 7. Clinicians should evaluate benefits and risks with patients within 1 to 4 weeks of starting opioid therapy for subacute chronic pain or dosage escalation. Clinicians should regularly reevaluate benefits and risks of continued opioid therapy with patients. So you don't just prescribe the opiate for the patient, have those refill requests coming through, and you're just filling them without reevaluation. So this can be another barrier, a barrier that we see in my clinic in rural Arizona, and a barrier you might see is there's just not enough clinicians, not enough appointment times to get that patient back in for a timely manner to reevaluate. So that definitely can be a challenge for myself, and I'm sure at some of your organizations. So moving along for the sake of time, number 8, before starting and periodically during continuation of opioid therapy, clinicians need to evaluate risks for opioid-related harms and discuss risks with the patient. Clinicians should work with patients to incorporate into the management plan strategies to mitigate risk, including offering naloxone. So naloxone has become much more available over the years. Patients can get it now without a prescription. I still write prescriptions for naloxone for any of my patients that is on an opiate, even if I'm not prescribing it. Patients that are on opiate with other sedating psychiatric drugs that I may be prescribing. And of course, for the patient with that, that's receiving opiates and benzodiazepines. Hopefully that's a small minority of patients, but definitely making sure that they're educated on naloxone, and not just the patient. When I prescribe naloxone, give naloxone, encourage naloxone to the patient and their family. I always introduce, you might not use this on yourself, but there is an opiate epidemic. So keep it on you, and you could save the life of a neighbor, a stranger. Keep it on you, know how to use it. Call 911 first and administer according to package directions. So moving on to recommendation number 9, when prescribing initial opioid therapy for acute, subacute, or chronic pain, and periodically during opioid therapy for chronic pain, clinicians need to review the patient's history of controlled substance prescription using that PMP. So back to the PMP data, having that easy access, that it is in your electronic medical record. If it's not, your organization definitely needs to work on that. Recognizing some of the limitations of the PMP, as we've already discussed, but using it like as essential to the safe prescribing of your medications. So recommendation number 10, when prescribing opioids for subacute or chronic pain, clinicians should consider the benefits and risks of toxicology testing to assess for prescribed medications, as well as other prescribed and non-prescribed controlled substance. So we're definitely doing the urine drug screening. We're making ourselves aware of what tests are going to detect what substances. So some of your like classic like UDS-8 may not detect the synthetic opiates that your patient may be exposed to, like fentanyl, which is the largest substance being abused on the streets these days. Fentanyl, carfentanil, methadone. Some of those synthetic opiates may not show up in standardized testing, so make sure you're using a test to capture that. Really, ideally, the tests need to be done randomly, which takes a collaboration of your ancillary staff, right, to do those random drug tests. And knowing that if a toxicology test does come back with unexpected findings, that this should not be a reason, or sometimes some providers are just looking for any reason to discontinue. They already want to discontinue, but they find this an easy reason to discontinue. Abrupt discontinuation and withdrawal is not going to help your patient and will likely contribute to opiate dependence and potentially death. So not recommended. So monitoring, definitely recommended. Toxicology, random urine drug screens, definitely recommended. But then once faced with that information, using it to comprehensively review with the patient and ensure that ideal treatment continues, not used as a punishment. Clinicians, number 11 recommendation, clinicians need to use particular caution when prescribing opioid pain medication and benzodiazepines concurrently, and consider whether benefits outweigh risks of concurrent prescribing of opioids and other central nervous system depressants. Benzodiazepines were never recommended for long-term use, and this is like a particularly passionate topic for me. I wish I had more time to talk about that, but just keep in mind those benzodiazepines were never recommended for long-term use. Sometimes introducing them for any period of time can easily lead to dependence, and many of our opiate deaths now involve additional substances combined, and benzodiazepines are often found in the death rates. And like I said, I wish I had more time to talk about that, but that could be a whole discussion on its own. But really use caution in those duplicate prescribing of the benzodiazepine and the opiates, recognizing, again, if someone's been on benzodiazepines for years, abrupt stopping of that is going to do more harm than good. So you can't just wash your hands and say that that script is over. We have to work on a plan to taper, mercifully taper. All right, number 12, the last recommendation. Clinicians need to offer or arrange treatment with evidence-based medications to treat patients with opioid use disorder. That's definitely a big role. A lot of what I do is treating adult patients with medication-assisted treatment. Detoxification on its own without medication for opiate use disorder is not recommended for opiate use disorder because of increased risk for resuming drug use, overdose, and overdose death. Conclusion and resources. So just to summarize, we're almost out of time, so I'm going to let you review this slide on its own. We definitely want to gather our data and monitor our progress and adjust our treatment protocols accordingly. And then you're going to be sent I believe you're going to have access to these slides. You're going to be sent all of these wonderful resources, some of which you can see here. And I know I've talked a long time. I've talked quickly. I hope all of you were able to understand and kind of get these main tips that you can research more on your own and think of ways that you can put these practice recommendations and this wealth of research into practice, which is always a challenge. Does anyone have any questions, comments?
I know
Well,
oh, go ahead. Go ahead,
you know,
Rocio.
go ahead.
Well, I was going to say, I know this, the University of Arizona Center for Rural Health and the Comprehensive Center for Pain and Addiction sponsored this webinar, but it really is, it speaks to the whole country. So that's why we were able to share this with other flex programs in the United States. So I hope that this was of value to you all. And did you put in the link to the survey?
No. Can you
No.
include it, please?
I don't have the link. Do you, Rocio?
No, I don't.
Okay, so we'll send it out in a different email for you to all fill out. But it's important to fill out the survey so that we can, you know, improve upon what we're doing here at the Center for Rural Health and the Flex programs, and your Center for Rural Health from whichever state you're from. So go ahead, Rocio.
Well, just thank you, everyone. We're over 4 minutes. I expect a follow-up email from us with all resources and links. And thank you, Dr. Mary Tulinnye, for your great presentation. Thank you,
You're
everyone.
welcome.